have no conflicts.
Good afternoon and welcome. Dr. Fry.
Sharon Fry. I am a professor of internal medicine at St. Louis University in St. Louis, Missouri, and I am a site principal investigator for 2 COVID phase 3 vaccine trials.
Good morning, welcome. Dr. Hunter.
Paul Hunter, Associate Professor of Family Medicine and Community Health at the University of Wisconsin in Madison, Wisconsin. I have a small grant for a quality improvement project on pneumococcal vaccines from Pfizer. Thanks.
Thank you. Good morning. Dr. Lee.
Grace Lee, Associate Chief Medical Officer at Stanford Children's Health and Professor of Pediatrics, Stanford University School of Medicine. I have no conflicts.
Good morning. Ms. McNally.
Good morning. Veronica McNally, President of the Franny Strong Foundation located in Michigan, and I have no conflicts.
Good morning. Dr. Paling.
Good afternoon. This is Kathy Paling. I am Professor of Pediatrics and Epidemiology and Prevention at Wake Forest School of Medicine and Director of Pediatric Population Health. I have no conflicts. Thank you.
Good afternoon and welcome. Dr. Sanchez. Dr. Sanchez? We'll come back to Dr. Sanchez. Dr. Szilagyi.
Hi, can you hear me? I was having audio problems.
I can hear you.
Okay, thank you.
Yes.
Great. Peter Szilagyi, Professor and Executive Vice Chair of the Department of Pediatrics at UCLA, and I have no conflicts.
Good morning, Dr. Szilagyi. Dr. Talbot.
Good morning. I'm Kip Talbot. I'm an Associate Professor in the Division of Infectious Diseases in the Departments of Medicine and Health Policy, and I have no conflicts and no dog today.
Good morning. Dr. Sanchez. All right, we'll come back around after I call roll on the ex officios and liaison representatives. So let me begin then with Dr. Messonnier from the Centers for Disease Control and Prevention.
Good afternoon. It's a busy few days. I'm pleased to give a few updates on activities related to COVID. Let me start by saying that we've had notable declines in pediatric immunization, including vaccine ordering, outpatient visits, and routine childhood vaccines starting in March 2020. As a result, children and communities are at increased risk for preventable diseases and outbreaks. Even though in recent months, some weeks are comparable to the same week last year, there is still a large cumulative deficit indicating the need for substantial catch-up. Just to put some numbers to it, for the Vaccines for Children's program, there is a deficit of more than 9 million doses overall and 1.2 million doses of measles-containing vaccine. The data sources show a faster recovery on the private sector side. We're urging healthcare systems and healthcare providers to identify families whose children have missed doses and contact them to schedule appointments, prompt clinicians when these children are seen to deliver vaccines that are due or overdue, and let families know what precautions are in place for safe delivery of in-person services. It is National Influenza Vaccine Week, and since influenza preparation has been so closely tied to COVID, I'd be remiss not to mention this year's flu vaccine efforts. So far this year, 188 million doses of flu vaccine have been distributed in the U.S. That's the highest number of doses distributed in the U.S. in a single season. Back a little bit more directly to COVID, we've had many conversations about our work in preparing for authorizing and distributing of a vaccine for COVID, but I do want to share a few highlights of CDC's other work in responding to COVID-19. 1,440 CDC deployers have conducted 2,694 deployments in 233 cities across the United States and abroad. A total of 7,893 CDC personnel have supported the outbreak response so far, and today there are more than 450 CDC staff supporting the work of our vaccine task force. The MMWR, sometimes called the voice of CDC, has published more than 160 COVID-19 articles since the beginning of the pandemic. One of the most recent was the publication of ACIP's interim recommendations for allocating initial supplies of COVID-19 vaccine, published December 3rd. CDC has awarded over $12 billion to states, localities, territories, and tribes. To date, we've provided $140 million to jurisdictions for flu season support, in addition to $200 million for COVID vaccine planning. Later this month, we'll provide the next tranche of COVID vaccine planning funding to jurisdictions with a total amount of $140 million. CDC has produced 4,113 documents providing information and guidance for government agencies, businesses, and the public regarding COVID. And in preparing to distribute and administer the COVID vaccine quickly and efficiently, CDC has worked with our many partners in state and local health departments and throughout the country. 41,000 COVID-19 providers are enrolled in VTREX. That includes more than 20,000 pharmacy providers, and many of those pharmacy providers will help us to reach the 55,000 long-term care facilities covering more than 3.5 million persons that have been enrolled in our federal pharmacy partnership. Specific to vaccine activities, we've had more than 150 partner meetings in the last few months, reaching almost 1 billion participants. And finally, one more note, a chief health equity officer was added to the COVID response for the first time ever in May to engage national partners addressing health equity in the context of COVID-19. In August, the Chief Health Equity Officer released a health equity strategy, which is available on our website and continues to guide our response efforts, including our efforts around COVID vaccine. Thank you very much for your time.
Thank you, Dr. Messonnier. So I have it, I understand now that Dr. Sanchez has his audio problem fixed. Let me call him for role and state your institution and conflict of interest, if any. Dr. Sanchez? Perhaps not yet solved. Okay, so let's do the following. Let's return to the ex officio representatives. I'm going to ask the ex officio representatives to hold on their reports until the end of roll call, and then we'll come back and start with Dr. Hans. So let me move forward then. Centers for Medicare and Medicaid Services. Dr. Hans, please indicate whether you're present.
Present, thank you.
Thank you very much. Dr. Fink from Food and Drug Administration.
Present.
Thank you, sir. Dr. Rubin, Health Resources and Services Administration.
Present.
Thank you. Welcome. Dr. Weiser from Indian Health Services.
Dr. Weiser is present.
Thank you. Dr. Bajol from National Institutes of Health.
Present.
Thank you. Dr. Beckham from the Office of Infectious Disease and HIV/AIDS Policy.
It's Dr. Kim who is replacing Dr. Beckham for this meeting. Dr. Romero?
Thank you very much, Dr. Kim. Very good. So it seems that Pablo may have, Dr. Sanchez may have his audio problem resolved. Let's try again. Dr. Sanchez, please state your institution and any conflict of interest if there is. Okay, maybe still a little bit to go. All right, let me turn now to the liaison representatives, and I'll begin with Dr. Rockwell from the American Academy of Family Physicians.
Present.
Dr. Maldonado from the American Academy of Pediatrics.
Present, and also joining me, Dr. David Kimberlin, editor of the Red Book for the American Academy of Pediatrics.
Thank you. I'll mark you as present, Dr. Kimberlin. Thank you. American Academy of Physician Assistants.
Hi, Marie-Michelle Leger, and I'm joined with Sandra De Palma.
Thank you, Dr. Leger. and Dr. De Palma. American College of Health Association.
Hi, this is Sharon McMullen from Cornell University, and I'm joined by my co-liaison representative, Dr. Kaylee Chai from the University of North Carolina at Chapel Hill.
Welcome both. American College of Nurse Midwives.
Carol Hayes, present.
Thank you, welcome. American College of Obstetricians and Gynecologists.
This is Dr. Linda Eckert from the University of Washington, representing the American College of Obstetricians and Gynecologists. Thank you.
Thank you, welcome. American College of Physicians.
Dr. Jason Goldman, affiliate professor at Nova Southeastern and Florida Atlantic University, General Internal Medicine. Pleasure to be here. Thank you.
Thank you, sir. American Geriatric Society.
Finch Bader, present.
Thank you. America's Health Insurance Plans.
Bob Gluckman, present. Thank you.
Thank you. American Immunization Registry Association.
Good afternoon. Rebecca Coyle is here representing ERA.
Welcome. Thank you. American Medical Association.
Sandra Freyhofer, liaison for the American Medical Association. I'm a practicing general internist and adjunct associate professor of medicine at Emory University School of Medicine in Atlanta.
Thank you. Welcome. American Nurses Association.
Chad Riddle, present.
Welcome. American Osteopathic Association.
Stan Grog, present.
Welcome. American Pharmacists Association.
Good morning. This is Steve Foster.
Good morning. Welcome. Association of Immunization Managers.
Molly Howell, representing AIM.
Good morning. Welcome. Association for Prevention, Teaching, and Research.
This is Paul McKinney, professor, University of Louisville School of Public Health and Information Sciences.
Welcome. Association of State and Territorial Officials.
This is Nirav Shah, Director of the State of Maine Center for Disease Control, on for ASTO.
Welcome and thank you. Biotechnology Innovation Organization.
Phyllis Arthur, present. Good morning. Oh, good afternoon.
Good morning or good afternoon. Thank you. Council of State and Territorial Epidemiologists.
Dr. Christine Hahn, State Epidemiologist of Idaho.
Thank you very much. Welcome. Canadian National Advisory Committee on Immunization.
She's not able to be on the call, Dr. Romero.
Thank you very much. Infectious Diseases Society of America.
Good morning, Jeff Duchin, Infectious Diseases Society of America.
Thank you. International Society for Travel Medicine.
Elizabeth Barnett, present.
Good morning. National Association of County and City Health Officials.
Matt Zahn, representing HO, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Greetings, Patsy Stinchfield, representing NAPNAP.
Hello and welcome. National Foundation for Infectious Diseases.
Good morning. This is Bill Schaffner for the NFID.
Good morning. National Medical Association.
Good afternoon. This is Pat Whitley-Williams, National Medical Association.
Welcome. Pediatric Infectious Diseases Society.
Sean O'Leary, representing Pediatric Infectious Diseases Society.
Welcome. Pharmaceutical Research and Manufacturers of America.
Good afternoon. Corey Robertson, present.
Good afternoon. Welcome. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman representing SAM. Thanks.
Welcome. Society for Health Epidemiology of America.
This is Marcy Dries, Chief Infection Prevention Officer at Christiana Care, representing SHEA.
Welcome. Have I forgotten any liaison representative? Okay. Then at this time, we're going to take the reports. And let me begin by going back to Dr. Hance for the Centers for Medicare and Medicaid Services.
Thank you very much. I wanted to share an update focusing on cost sharing for COVID-19 vaccines. For most individuals enrolled in Medicare, Medicaid, and private health insurance, There are no out-of-pocket expenses related to COVID-19 vaccines. CMS issued both an interim final rule and a series of toolkits on October 28th addressing this. They are available at cms.gov/COVIDVAX. That's COVIDVAX. The interim final rule was effective on November 2nd and published in the Federal Register on November 6th. Specifically, for Medicare, the CARES Act included COVID-19 vaccines in Medicare Part B without cost sharing for Medicare beneficiaries. For those beneficiaries enrolled in Medicare Advantage plans for years 2020 and 2021, the administration fee will be paid through fee-for-service Medicare. For those in private insurance coverage, the CARES Act also required non-grandfathered group or individual health insurance coverage plans to cover COVID-19 preventive services, which includes any ACIP recommended vaccine without cost sharing. In addition, the interim final rule requires that there is no cost sharing for those individuals in non-grandfathered group or individual health insurance plans who receive COVID-19 vaccines from out-of-network providers. For Medicaid, the Families First Coronavirus Response Act includes an increased federal matching rate for states with a condition of receiving that matching rate being that states cover COVID-19 testing services and treatments, which include vaccines, without cost sharing. There is a small exception for those enrolled in Medicaid limited benefit groups. The temporary matching rate increase is in effect until the end of the quarter in which the public health emergency ends. Currently, all states have opted to claim the temporary rate increase. The Medicaid toolkit also describes vaccine coverage outside of the public health emergency, with cost sharing prohibited for many categories of Medicaid eligibility outside of the public health emergency. For uninsured individuals, providers will be able to be reimbursed for administering COVID-19 vaccine through the Provider Relief Fund administered by the Health Resources and Services Administration. CMS intends for these toolkits to be living documents, and therefore they are being updated as needed. Again, all of this information is available at cms.gov/COVIDVAX. That's COVIDVAX. Thank you.
Thank you. Dr. Fink, please, FDA.
Hello, good afternoon. Yesterday, FDA convened the Vaccines and Related Biological Products Advisory Committee to discuss the emergency use authorization request for the Pfizer BioNTech COVID-19 vaccine. The agenda for yesterday's VRPAC meeting included, after an introduction by myself, 3 presentations from representatives of the Centers for Disease Control and Prevention, one on an update on COVID-19 epidemiology, one on plans for vaccine and safety and effectiveness monitoring should the vaccine be authorized for use under an EUA, and one on operational distribution plans for the vaccine under an EUA. We then had a presentation on considerations for placebo-controlled trial design if an unlicensed vaccine were to become available under an EUA. We had an open public hearing, and then in the afternoon, we spent most of the time hearing about details of the clinical trial results, first presented by Pfizer, and then in FDA's own independent analysis to cover the clinical data submitted in support of Pfizer's emergency use authorization request. Following those presentations, we had a committee discussion on 2 items, neither of which they were asked to vote on. The first of these items was a discussion of Pfizer's plan for continuation of blinded placebo-controlled follow-up in ongoing trials if the vaccine were made available under the EUA. Pfizer has proposed to make vaccine available to placebo recipients if and when those placebo recipients would otherwise have access to the vaccine under the conditions of the EUA, recommendations from federal, state, and local prioritization for use of the vaccine and vaccine availability. In that situation, study participants who would be requesting the vaccine would be unblinded to their treatment assignment. And if they previously received placebo, they would be administered the vaccine in study visits with scheduled follow-up. The second discussion item was to ask the committee to discuss any gaps in plans described for further evaluation of vaccine safety and effectiveness in populations who receive the vaccine under an EUA. In terms of the first question about continuation of blinded placebo-controlled follow-up, the committee discussed that preservation of placebo-controlled follow-up for as long as is feasible should be attempted, but they certainly acknowledged that placebo recipients should not be denied the opportunity to receive vaccine if they would be otherwise eligible for the vaccine under the conditions and availability of the vaccine under EUA. In terms of the second question, the committee did express the need for continued evaluation of the vaccine, specifically to gather more information on safety in specific populations, including HIV positive individuals, as well as data on SARS-CoV-2 shedding and transmission and the impact, if any, that the vaccine might have on those parameters. Following these discussion items, the committee was asked to vote on a single question, which is whether, based on the totality of the scientific evidence available, to the benefits of the Pfizer-BioNTech COVID-19 vaccine outweigh its risks for use in individuals 16 years of age and older. A large part of the discussion surrounding this question involved concerns raised by some of the committee members that available data in individuals ages 16 to 17 years were very limited, and thus they thought, in their opinion, that an emergency use authorization should only include individuals ages 18 and over. However, other committee members thought it would be reasonable to extrapolate a favorable benefit risk balance for individuals 16 and 17 years of age based on safety and effectiveness data available for younger adults ages 18 and above, and also supported by the available safety data from the clinical study in participants 16 and 17 years of age who were enrolled in that study. There was also further discussion about the small numbers of severe COVID-19 cases in the trial that provide direct evidence of vaccine effectiveness against severe COVID-19. However, as discussed by FDA and some other members of the committee, extensive experience with preventive vaccines has demonstrated that vaccines that are effective against mild to moderate disease are also effective against severe disease. There's no expectation that this would not be the case for this COVID-19 vaccine, and available data from the clinical trial support the likelihood that the vaccine will be effective against severe COVID-19. There was one committee member who expressed a concern that further follow-up in clinical trials was needed prior to issuance of an EUA. Following this discussion, the committee voted on the question, and the results of the vote were 14 committee members in favor, 4 committee members against, and 1 abstaining. And thus, the vote of the VRPAC was in favor of a determination that the benefits of the Pfizer-BioNTech COVID-19 vaccine outweigh its risks for use in individuals 16 years of age and older based on the totality of scientific evidence available. FDA is now taking the VRPAC vote and discussion into consideration as we continue and work on finishing our review of the EUA application. Thank you very much.
Thank you, Dr. Fink. Next, Dr. Rubin from Health Resources and Services Administration.
Good afternoon. The Division of Injury Compensations don't have any updates.
Thank you very, very much. Dr. Weiser, Indian Health Services.
Good morning. The Indian Health Service has been working closely with CDC and Operation Warp Speed to prepare for COVID-19 vaccine distribution and administration. IHS COVID-19 Vaccine Task Force has numerous trainings regarding new reporting systems, developed priority population estimates with direct input from federally recognized tribes, and mapped out distribution pathways for the 330 clinical sites that will be receiving their vaccines through the direct IHS allocation. Tribal and urban programs were given the option to receive vaccines through IHS or their respective state allocations, and 150 tribal and urban programs opted to receive vaccines through their state immunization programs. IHS has also strengthened vaccine safety monitoring, including VAERS and the VSAFE program in cooperation with CDC, and a sentinel surveillance program for active surveillance of adverse events has also been established. Each IHS area is working closely with their federal IHS, tribal and urban Indian health programs, as well as tribal epidemiology centers and representative tribal health boards to coordinate all aspects of carrying out a successful COVID-19 vaccine program. Thank you.
Thank you. National Institutes of Health.
Yeah, hi, good afternoon. Just a few updates from the NIH floor. On the vaccine side, last week, NIAID and Moderna published in New England Journal of Medicine a letter detailing the 3-month follow-up from the phase 1 study. That's 3 months after the second dose, day 119 of the study. And that data point is important because it gives the first clear evidence of the longevity of that vaccine. Earlier last week, NIAID and Moderna also announced the interim results of their phase 3. NIAID's been part of the design and implementation of that with many sites from across many programs at the NIH supporting that study. That's going to be the focus of VRPAC and ACIP next week, so we won't go into the details. And lastly, shifting to the therapeutic side, the ACTT study, which did the remdesivir study, just today published the findings of ACTT2, which is the baricitinib. That is the trial that supported the EUA of baricitinib as an anti-inflammatory therapy on top of remdesivir. And that is published in New England as of a few hours ago. We will have more written updates, but that's all for the verbal updates. Thank you.
Thank you. Office of Infectious Diseases and HIV/AIDS Policy. Office of Infectious Disease and HIV/AIDS Policy.
Dr. Romero, David Kim is not on the line. Apologies.
Okay. No, thank you very much. Did I miss any of the ex officios? Okay. Let me go back and and call
Dr. Romero, can you hear me now?
Yes, please, go ahead.
Oh, my apologies. I thought I had checked in earlier during the roll call as well. It turns out that I was on mute the entire time. Anyway, regarding the OIDP update, I have three specific items that I'd like to present to the committee. The first is the National Vaccine Plan. I'd like to thank all the organizations represented at this committee meeting for the comments that they have submitted for the public comment period on the latest draft of the National Vaccine Plan. We are presently in the process of adjudicating these public comments and to prepare the final report, which we expect to be released in January 2021. On the vaccine safety report, this is a report that OIDP releases, and the last report was published in 2014. And we're in the process of updating it. This too has gone through a public comment period, and we're like the National Vaccine Plan, we're in the process of adjudicating the public comments, and we expect this report to be released in March 2021. And one more item, and that's the NVAC, this National Vaccine Advisory Committee meeting that was held a week or two ago. It was opened with the Assistant Secretary for Health, Admiral Gerard, and Dr. Stanley Plotkin, and their opening was followed by approaches to include pregnant women in COVID-19 clinical trials and discussions that followed, and also vaccine safety systems and COVID-19, and discussions on co-pays coverage for COVID-19 vaccines by CMS. The committee meeting was also included a vaccine confidence report overview by the chair of the committee, Dr. Robert Hopkins, and a vote was taken to accept that report in its entirety for submission to the Assistant Secretary for Health. And that concludes my remarks for OIDP updates.
Thank you, Dr. Kim. Did I forget anybody else from the ex officio representatives? Okay. Let me see if Dr. Pablo Sanchez is able to connect via audio. I believe not. Dr. Sanchez?
Can you hear?
Yes, we can hear you now.
Okay.
Please state your affiliation and any conflict.
Pablo Sanchez, Professor of Pediatrics, Neonatology and Pediatric Infectious Diseases at Nationwide Children's Hospital and Ohio State University in Columbus. And no conflicts.
Thank you very much. So I will see if Dr. Cohn or Dr. Messonnier have any other comments before I begin to call the next the speakers.
Dr. Romero, I think we are ready to go and appreciate all of the updates from the other agencies. We really, this is clearly an all of government response, and we appreciate everyone's partnership.
Thank you. All right, so we will move on to the first item for today, which is coronavirus disease 2019 vaccines. We'll begin with an introduction by Dr. Bell. Dr. Bell.
Thank you very much, Dr. Romero. Thank you, and welcome to everyone. Before I begin, I just would like to reflect on the fact that in the last week, we've seen an average of over 200,000 cases of COVID-19 every day in the United States. We have more people in the hospital suffering from this condition than at any point so far in the pandemic. When we met 9 days ago, I offered the sobering statistic that there was 1 American dying of COVID-19 every minute. Today, sadly, I have to report that there are now 2 people dying every minute. And indeed, on December 9th, there were 3,411 deaths in the United States. So there is undoubtedly a huge amount of suffering at the moment in the United States. And during this meeting, where we will review evidence about one of the vaccines that has an application pending at FDA and discuss interim recommendations, offers some hope for the future. Next, please. As a reminder, our most recent ACIP emergency meeting was on December 1st, where we voted on and approved an interim recommendation for allocating initial supplies of COVID-19 vaccine in phase 1A to include healthcare personnel and residents of long-term care facilities. On November 23rd, the previous meeting, the ACIP reviewed the evidence to recommendation framework, including the public health problem, resource use, equity, values, acceptability, and feasibility, and continued a discussion of phased allocation of COVID-19 vaccines. Next. Now, just a summary of the COVID-19 work group activities in November and December. I keep having to increase the frequency of our work group meetings when I report, since we're meeting even more frequently than previously. So we've been meeting 1 to 2 times per week. And since the last ACIP meeting on December 1st, I guess, we covered the safety and efficacy of the Pfizer-BioNTech COVID-19 vaccine. We heard a presentation of the grade analysis of this vaccine. We discussed the balance of the benefits and possible harms related to the vaccine. And we had some additional discussions about phase 1 and 1B and 1C populations. Next. So today's agenda, again, as Dr. Cohn mentioned, this is a 2-day meeting, but today's agenda includes the Pfizer-BioNTech BNT162b2 COVID-19 vaccine development program presented by Dr. William Gruber from Pfizer, the grade analysis of this vaccine presented by Dr. Julia Gargano from CDC, and the work group interpretation of evidence and next steps presented by Dr. Sarah Oliver. Next. Next steps, which this is already out of date. Next steps will be that ACIP's second day of this meeting is scheduled to meet either December 12th or December 13th. And if FDA has issued an emergency use authorization for the Pfizer-BioNTech vaccine, ACIP will vote on recommendations for use in the United States. Next. Again, I just display this slide with the members of the work group as a way to express my appreciation for their dedication and participation. Next. And similarly, the CDC participants. Thank you very much, and I will yield back to Dr. Romero.
Thank you very much, Dr. Bell. So we'll move on to presentation by Dr. Gruber from Pfizer on the BNT162b2 development program. Dr. Gruber, please.
click, there are some build. If I say click, that means click, and it'll move through the slide and add the necessary information. So again, as shown on this slide, our COVID-19 mRNA vaccine is called BNT162b2 and has been developed for the following indication: prevention of COVID-19 in individuals 16 years of age and older. The dose level is 30 micrograms with 2 doses given 21 days apart, and the current vaccine presentation is a 5-dose multi-dose vial that is preservative-free and stored frozen between -80 and -60 degrees Celsius until use. We go to the next slide, please. I'm going to begin with a very brief summary of the non-clinical data that encouraged us to move forward. And then I'll include with this both toxicity studies as well as the study looking at the challenge model in rhesus macaques. And these studies are described in a briefing document that I think many of you have access to and is now publicly available based on its being provided for the VRBPAC presentation. If we go to the next slide, please. So 2 toxicity studies were conducted in rats, including the BNT162b2 vaccine construct, and these were completed with no safety concerns. If you could click for me. Development and reproductive toxicity studies are ongoing with preliminary results available by mid-December. And click again, please. In a SARS coronavirus 2 rhesus challenge model, the BNT162b2 construct provided complete protection in the lungs as determined by nucleic acid amplification testing for SARS coronavirus 2 and bronchoalveolar lavage fluid. And this information is now published. Importantly, there was no radiologic or histopathologic evidence of vaccine-elicited disease enhancement. Despite the recognized limitations of animal models, these findings anticipated results in our phase 3 clinical trial in which there is no evidence of enhanced disease. The overall results of the toxicity as well as the challenge studies were encouraging. They satisfied FDA guidance criteria and permitted progression of human clinical trials into later phases. We go to the next slide, please. I'm now going to share with you the clinical safety, immunogenicity, and efficacy data from our overall clinical development program. Next slide, please. First, I will cover safety and immune response from the German and US studies, and then cover aspects of the phase 2-3 trial, finishing with safety and efficacy results. Now, if we go to the next slide, please. Let's start with the 2 phase 1 studies. The German phase 1 dose ranging study was conducted in individuals 18 to 55 years of age. 12 subjects received the active BNT162b2 vaccine for each dose level cohort. This study evaluated safety, binding and neutralizing antibody responses, as well as cell-mediated immune response to look at the potential for Th1 bias, CD4, and CD8 T-cell responses. The US study on the right-hand side is a seamless study where we had a phase 1 portion that moved into phase 2 and then phase 3. For the phase 1 dose ranging portion, we included 18 to 55 and 65 to 85-year-old individuals, 12 of whom received vaccine and 3 received placebo per dose level cohort. We looked at safety and immunogenicity with both binding and neutralizing antibody responses and followed reactogenicity by e-diary. These individuals will continue to be followed for a full 2 years after the second dose. The results from the phase 1 experience have now been published, and you have details in the briefing document. Next slide, please. I'll just summarize for you briefly the reactogenicity in phase 1 and spend more time on that and talking about the phase 2-3 reactogenicity profile. Mild to moderate injection site pain was observed frequently and was consistent with local reactions observed with other commonly licensed and recommended adult vaccines. Fever and chills, along with other systemic manifestations, were observed. Reactogenicity was generally higher after dose 1 than dose 2, and reactogenicity events after each dose of the vaccine in older adults were milder and less frequent than those observed in younger adults. Next slide, please. Now, I'd like to summarize for you the antibody responses in phase 1
to two 30 microgram doses of the chosen BNT162b2 vaccine, focusing on the neutralizing antibody titers from the US-based trial. These results have been published in a peer-reviewed journal and are described in the briefing document. If you could click for me, please. By day 28, or 7 days after the second 30 microgram dose, true 50% neutralizing antibody responses are observed. GMTs are shown at the top of each column. Antibody responses are well maintained out to day 52, approximately 1 month after dose 2, in both this younger 18 to 55 years of age group, as well as, if you'll click for me again, the older 65 to 85 years of age group. GMTs are again shown at the top of each column. If you click again for me, please. The GMTs in the vaccinated participants range from 1.5 to 3.8-fold higher than the virus neutralizing geometric mean titers of 94 observed in a panel of 38 human convalescent serum, and this is labeled HCS. So these results were encouraging that we were achieving a functional antibody response that could be associated with protection. We go to the next slide, please. It was also very important for us to examine cell-mediated immune response to be confident that we were getting a Th1 biased CD4 and strong CD8 T cell response. If you click for me, these are data from the German trial, and the first panel show gamma interferon intracellular cytokine analysis data. We see a substantial increase in gamma interferon, very consistent with Th1, and at levels above responses following natural infection, labeled HC. You could click again. If you look at the middle panel, you can see a relatively higher proportion of S-specific CD4 cells expressing gamma interferon, IL-2, or both, compared to a lower proportion expressing IL-4. So once again, emphasizing a Th1 bias that could be associated with protection. And likewise, not only is it important to demonstrate the CD4 responses and the concomitant potential for inducing memory, it was important to demonstrate CD8 T cell response to indicate the potential for virus killing of infected cells. If you could click again, please. So in the right-hand panel, you see a robust CD8 T cell response that exceeds responses observed from natural infection, again labeled HC. So on the basis of promising neutralizing antibody response, Th1 biased CD4 response, as well as the robust CD8 immune response, we were encouraged to move into the phase 2-3 portion of the study, of the clinical study, with the BNT162b2 vaccine construct. If I could have the next slide, please. Outlined here for you at a very high level are the fundamental elements of the trial, where our goal is to enroll approximately 44,000 healthy subjects. Stable chronic disease was allowed because we find it important to make sure that those individuals with underlying diseases are included. They stand to have the greatest benefit from a vaccine because of their high morbidity associated with COVID-19. We have also included individuals with stable HIV, hepatitis B, and hepatitis C virus infection. At least 40% of participants are 56 years of age or older. And again, this is important because we recognize that this population is also particularly vulnerable to severe disease. We also recognize the importance of conducting this study in people of color. So we've adopted an approach that assures a diverse racial and ethnicity profile, including Black and African American populations, Asians, and Hispanic Latinx populations. We've excluded immunocompromised individuals because it's yet to be determined if different dosing might be required in this population. As you'll see later, we plan to evaluate those populations in future studies. We go to the next slide, please. So here then are the demographics displayed for the full population data cut on over 43,000 subjects on November the 14th, with good representation of gender, race, ethnicity, and age, with even splits between vaccine and placebo recipients. If you could click for me again, please. The age breakdown is highlighted to show the different age groups above and below 55 years old. And in the older 65 and above groups, and if you can click again, please, Note that over 9,000 or 20.9% of the 43,000 plus participants were over 65 years of age. If we go to the next slide, please. So now let me share with you the safety data from the phase 2/3 portion of the clinical trial. Next slide, please. First, I wanted to highlight something that I think is very familiar to members of the ACIP committee. We have ongoing safety reviews by an independent data monitoring committee of unblinded safety data. And in fact, these are occurring weekly. This makes sense in the context of a rapidly enrolling trial with this new vaccine candidate. The DMC consists of 4 adult or pediatric infectious disease experts and 1 statistician, all with expertise in assessing vaccine safety, immune response, and efficacy. And this DMC, as recently as this past week, has identified no safety concerns during the duration of the clinical trial and has recommended that the study continue as planned at all of their safety reviews. Next slide, please. This figure summarizes the safety database population submitted to the FDA for this review. Starting at the bottom, there are over 43,000 study participants with safety data collected in the trial as of the data cutoff on November the 14th. Moving up the figure, nearly 38,000 of these represent a subset with median safety follow-up time of 2 months post-dose 2, meeting FDA guidance. This means that there are over 19,000 participants for whom safety follow-up data is available for at least 2 months post-dose 2, shown in the second bar from the top. Of the total safety population, there are over 8,000 subjects, shown at the top, from whom 7 days of solicited local and systemic reactions were obtained by electronic diary. Next slide, please. Shown here is a schematic of how safety of subjects was monitored. On the left-hand side at the top, vaccination doses were given 21 days apart. The first dose of vaccine was followed by very intense active surveillance for potential COVID-19 symptoms that would trigger a telehealth or in-person visit and nasal swab. This was done both as a safety measure as well as to evaluate efficacy. Individuals could either be swabbed at the investigative site or obtain a self-swab. We were intent, of course, on otherwise tracking safety comprehensively, and you can see at the bottom left of the slide that we used an electronic diary to address common reactions seen after vaccine administration, encompassing at least 6,000 subjects and at least 500 in each of the countries that are included in the trial. We also captured non-serious adverse events 1 month post-dose 2. We will actively collect serious adverse events for at least 6 months post-dose 2 and deaths and related SAEs out to the end of the trial at 2 years after the second dose. We go to the next slide, please. So now I'd like to share with you the electronic diary data related to local adverse events. This represents data that were captured over 7 days after dose 1 and dose 2 in 16 to 55 and 56 to 85-year-olds. I think you can quickly appreciate, looking at the 2 panels which represent dose 1 and dose 2, that for redness, swelling, and pain at the injection site, the type of local reactions are very consistent to those seen with commonly licensed and recommended vaccines with very little redness or swelling. Pain was largely mild to moderate in severity, and no grade 4 local reactions were observed. Again, a satisfactory safety profile as far as local reactions are concerned. If we go to the next slide, please. We also, of course, use the electronic diary to look at systemic events. The orientation of this slide is different in that we are looking first at events 7 days after dose 1 in those who received the vaccine on the top panel compared to those who received placebo on the bottom. Looking at both the 16 to 55-year-olds as well as the 56 to 85-year-olds, you can see that the reactions fall within a tolerable range compared to other adult vaccines. I would highlight fever and chills because these appeared to be the most discriminating, as you can see when compared to placebo, but both were within an acceptable range. Next slide, please. Now we are looking at systemic events 7 days after dose 2, and you can see a somewhat higher incidence of fever and chills as well as other systemic manifestations compared to placebo. The only grade 3 or severe solicited adverse events greater than or equal to 2% in frequency after the first or second dose were fatigue at 3.8% and headache at 2% following dose 2. One vaccine recipient reported a fever of 41.2 degrees centigrade only on day 2 after dose 2 and reported no fevers for all other reporting days. One vaccine recipient reported fever of 40.7 degrees centigrade on day 4 after dose 1 with no fever at the end of the 7-day reporting period. And I'll show you some more information about these fevers in comparison to placebo on a subsequent slide. Otherwise, no grade 4 systemic reactions were observed. There was a difference between younger individuals and older individuals. Younger individuals, again, tended to have more reactions. But in all age groups, the vaccine was well tolerated and the reactions were within an acceptable range. Next slide, please. If we consider how these events peak and decline over the 7-day post-dose 2 period in the vaccine group, it can be seen that the duration is short-lived. Participants are vaccinated on day 1. Fever, the leftmost dark blue bar, typically appears on the day after vaccination and lasts only a single day. Otherwise, systemic events, shown as other colored bars, peak at day 2, then rapidly decline over the next 2 days in both age groups. Next slide, please. Severe or grade 3 local reactions are displayed for you here. Note that after both dose 1 and dose 2, severe pain at the injection site occurred in less than 1% of vaccine recipients, and the incidence of severe redness and swelling were even lower. If we go to the next slide, please. Fever or severe grade 3 systemic reactions after dose 1 are displayed here. I've already mentioned the one fever over 40 degrees centigrade in the vaccine recipient after dose 1. 2 such fevers were reported in placebo recipients. Severe systemic reactions all occurred in less than 1% of vaccine recipients, and for most findings, less than 0.5% of these participants, and each with an incidence comparable or higher than placebo. We go to the next slide, please. Likewise, after dose 2, the one high fever already mentioned was observed, and again, fatigue and headache were the only categories with grade 3 systemic events with an incidence exceeding 2%, with severe chills at 1.6% and others as shown, all with observed incidence somewhat greater than placebo. Next slide, please. We captured spontaneously reported adverse events by system organ class in the nearly 38,000 subject subset, for which median safety follow-up was 2 months after dose 2. This slide shows adverse events by system organ class occurring in 1% or more of the study population. More details are included in the briefing document. The most common adverse events observed were general disorders and administration site conditions. As shown in the footnotes, the top 4 classes of unsolicited reactions in this nearly 38,000 participant data set mirror the common reactions captured by electronic diary in the 8,000 participant subset previously described. For example, these include reports of injection pain, fever, myalgia. For nervous disorders, the highest proportion is headache, and for GI disorders, diarrhea and vomiting. We go to the next slide, please. When we exclude those terms reflecting local reactions and systemic events typically occurring within 7 days of vaccination, we see a more even split of adverse events between the active vaccine and placebo groups, apart from general disorders and administration site conditions, where the predominant remaining event is unspecified pain in the vaccine group, 2.4% versus 0.2%. In general, adverse events by system organ class are infrequent and within range of such reactions reported after other licensed vaccines. Next slide, please. This is a somewhat busy slide, but let me summarize the key elements. If we look at subjects reporting at least one adverse event, the observed frequencies of any adverse event showed some variability across racial and ethnic groups, but within a tolerable range. Little differences were observed when evaluating serious adverse events across these groups, as shown in the middle row, and AEs leading to withdrawal were similarly infrequent across racial and ethnic groups. Deaths were infrequent at the time of the November 14th data cutoff and distributed among these groups, with 2 in the vaccinated and 4 in placebo recipients. And I'll come back to those a little bit later as well. We go to the next slide, please. Rounding out this part of the safety review, serious adverse events shown here by system organ class are consistent with what we typically see in populations that not only include 40% of individuals being older than 55, but over 50% of the population being obese and or having at least one underlying morbidity. SAEs have been balanced between vaccine and placebo recipients. These include observed serious adverse events of special interest designated by the CDC, which are few in number and comparable between vaccine and placebo recipients. Next slide, please. I previously mentioned the deaths. Again, a total of 6 deaths have occurred in this population, with 4 of these in the placebo group, as of the data cutoff on November the 14th. None of these have been considered related by the investigator, and further description of the deaths, as well as the full safety data available, are included in the briefing document. Next slide, please. So in summary, the tolerability and safety profile of the BNT162b2 vaccine at 30 micrograms administered as a 2-dose regimen 21 days apart is favorable, and no clinically significant safety findings other than mostly mild or moderate reactogenicity have been identified. I'd now like to turn to our efficacy evaluation. Next slide, please. Next slide. So let me now summarize how we went about determining efficacy for the first primary efficacy endpoint. Again, the vaccine doses were administered 21 days apart, and to qualify for the first primary efficacy endpoint evaluation, individuals needed to have no evidence of prior or current infection before each dose. And that was determined either by obtaining a swab at the time of each dose to identify evidence of SARS coronavirus 2 by nucleic acid amplification testing, or obtaining a blood specimen for N-antigen antibodies at the time of the first dose to indicate evidence of prior infection that may have preceded vaccination by months. So this allowed us to be confident that the individuals, for the purpose of this primary endpoint, had no evidence of prior or current infection at the time of each dose. And we see this as important because this is the group that we would all anticipate is most vulnerable to SARS coronavirus 2 disease, or COVID-19. And then, as I already mentioned, we have active surveillance for potential COVID-19 symptoms that trigger a telehealth or in-person visit and a nasal swab. And we will continue to do this for up to 2 years after the second dose. Next slide, please. So now let me summarize for you what constitutes a case definition. To qualify as a case for the first primary endpoint case definition, individuals had to be baseline negative by serology and PCR for prior or current infection. And then we characterized the illness as needing to include one or more of these symptoms, and these should be familiar to you because they largely coincide with symptoms that are captured by the CDC case definition, but with a bit more potential specificity. Comparable efficacy observed in the trial, encompassing all the CDC criteria, are shown in the briefing document. And then on the right-hand side, once an individual qualifies for those first 2 categories, they need to have a positive validated PCR, either in our central laboratory, or results will be accepted from a local lab if it's approved as a type of testing that we agree is valid. All testing, of course, was performed blinded to treatment assignment. And so it's this combination that determines the case definition for the efficacy results that I'll be sharing with you now. Next slide, please. We performed an interim analysis at 94 cases in individuals without prior infection and an observed efficacy of 95.7%. We have now also performed the final vaccine efficacy evaluation against COVID-19 occurrence from 7 days after dose 2 in 170 cases without evidence of prior infection. Observed efficacy is high at 95% with high confidence based on the parameters shown in the 2 right-hand columns. There is 95% probability that efficacy falls in the interval shown, meaning over 97.5% likelihood that efficacy is greater than 90%. Likewise, the probability that vaccine efficacy is at least greater than 30% greatly exceeds the FDA COVID-19 vaccine guidance. Next slide, please. This efficacy trial was not powered to evaluate efficacy based on age stratum, gender, racial, or ethnic group. Nonetheless, we thought it would be useful for the ACIP to see vaccine efficacy broken down by these parameters. And as you can see, observed efficacy was high, regardless of age and consistent with overall results. 15 cases were seen in adults 65 to 74 years of age, and only one was in the vaccine group. 5 cases were observed in participants greater than or equal to 75 years of age, and all were in the placebo group. Likewise, as shown on this slide, efficacy was high in both males and females, and efficacy was high across racial and ethnic groups. Comparable high observed efficacy was observed across white, Black African American, or other racial groups, and likewise also across Hispanic and non-Hispanic ethnicity, with lower bounds of the confidence intervals above 80% across these ethnic groups. There were also comparable values of observed efficacy seen across geographies. Next slide, please. This efficacy trial was also not powered to evaluate efficacy based on risk groups. Nonetheless, we think it would be useful for the ACIP to see vaccine efficacy broken down by these parameters. The risk groups included individuals with BMI greater than 30 kilograms per meter squared and or those from the Charlson Co-Morbidity Index, which included malignancies, chronic pulmonary disease, chronic cardiovascular disease, diabetes, renal disease, and many others. As you can see, observed efficacy was high, regardless of whether the participants were at risk or not, consistent with overall results. Likewise, as shown on this slide, efficacy was high across age groups with and without risk, as well as those with or without obesity. We go to the next slide, please. If we break out comorbidity, we see that regardless of category, past history of malignancy, cardiovascular disease, pulmonary disease, diabetes, or the additional category of hypertension, point estimates of observed vaccine efficacy remain high, and for some, the nominal lower bound of the confidence intervals are well above 0. Hence, we can be confident that the vaccine is likely to work well in older or debilitated individuals. We go to the next slide. Likewise, we have now evaluated efficacy against COVID-19 from 7 days after dose 2 and those with and without prior infection, the second of the 2 primary endpoints. Efficacy remains high at 94.6% with similarly high confidence based on the parameters shown in the right-hand columns. Next slide, please. It was also important for us to define severe cases, both for evaluation of safety and for determinations of efficacy. And for this, we use the definition of severe COVID-19 based on FDA guidance. And that's summarized here for you in bullet form. ICU admission, clinical signs of severe disease, organ or respiratory failure, and death are key features. Next slide, please. Using this FDA definition of severe disease, let's look first at this top table. Although not statistically significant due to small number of cases, protection against the few cases of severe disease occurring at least 7 days after dose 2 is consistent with the overall efficacy results, with 1 case in the vaccine group and 3 cases in the placebo group in those without prior infection. However, if one examines the all-available population for first severe COVID-19 cases after dose 1, the bottom table, only 1 case is seen in the vaccine group and 9 cases are observed in the placebo group for an observed vaccine efficacy of 88.9%. The vaccine recipient only met a single FDA criterion for severe disease of O2 saturation below 93% and was not hospitalized. In contrast, out of the 9 placebo recipients with severe disease, 6 met 2 or more criteria, 6 were hospitalized, 3 were admitted to the ICU, and 1 was intubated or mechanically ventilated. This is consistent with overall vaccine efficacy seen 7 or more days after the second dose and indicates that the BNT162b2 vaccine is likely to protect well against severe or serious disease. Next slide, please. The FDA definition does not include hospitalization as a specific criterion for severe disease. However, the CDC definition of severe disease, shown in the light blue box, includes hospitalization, more severe outcomes of hospitalization, and death. We thought it would therefore be useful to perform a post hoc analysis of severe disease using the CDC definition to further assess the impact of vaccine on this outcome. Using this parameter, efficacy against severe disease greater than or equal to 7 days after dose 2 was observed, with 0 cases in the vaccine group and 5 cases in the placebo group, with the confidence interval as shown. Once again, protection was also observed for first severe COVID-19 occurrence after dose 1 of 92.9% with a 1 to 14 case split. And the lower bound of the 95% confidence interval in this case was well above 0. One vaccine recipient was hospitalized 12 days after receiving the first dose of vaccine, but without additional CDC-defined morbidity. Of the 14 placebo recipients hospitalized, 3 were admitted to the ICU and 1 was intubated or mechanically ventilated. This analysis provides evidence for vaccine protection against hospitalization and attendant morbidities. Next slide, please. This curve shows the cumulative incidence of all available COVID-19 cases beginning after dose 1. Placebo cases are shown in red, vaccine cases in blue. Darker dots represent severe cases using the FDA guidance definition, 9 in the placebo group and 1 in the vaccine group, with 2 instances where cases overlap graphically at day 8 and day 67 in the placebo group. One can see that by as early as 12 days and at least by 14 days, the curves begin to spread, indicating some efficacy after the first dose. Placebo cases continue to increase. The objectives met the success criteria. In individuals without prior SARS coronavirus 2 infection, observed vaccine efficacy against COVID-19 occurring at least 7 days after dose 2 was 95%, with high probability, 97.5%, that the true vaccine efficacy is at least 90%. And again, this meets the pre-specified FDA criteria for emergency use authorization. Observed vaccine efficacy was greater than 93% for the first primary endpoint across age, race, ethnicity, and at-risk subgroups. Next slide, please. Per the FDA definition, 9 severe COVID-19 cases were observed in the placebo group and 1 in the vaccine group as of the interim analysis cutoff date, and 14 hospitalizations and associated morbidities were seen in placebo recipients versus 1 vaccine recipient hospitalization in a post hoc analysis, providing evidence to support efficacy against severe disease consistent with that seen against all COVID-19. From the cumulative incidence curve, there is early onset of protection, with divergence of the placebo group from the BNT162b2 group as soon as 12 days and by at least 14 days, with steady accumulation of cases in the placebo group while the BNT162b2 group remains virtually flat. Overall, the efficacy results show that BNT162b2 vaccine at 30 micrograms provides protection against COVID-19 in participants who had or did not have prior SARS coronavirus 2 COVID-19 disease. Next slide, please. So now let me talk to you about our plans to meet FDA EUA guidance for risks and benefit during use of the vaccine under the emergency use authorization. You could click for me, please. First, I'm going to describe in brief pharmacovigilance plan. Since this vaccine is likely to be administered to millions of people in a short time, we've expanded our capacities to process adverse event reports with an online AE reporting portal. Our signal detection activities will occur on a more frequent cycle, and we have plans for future clinical studies to expand to the more vulnerable populations. If you could click again, please. Second, I want to describe briefly proactive risk minimization. Clear, comprehensive labeling and educational material for vaccine providers will emphasize key messages about appropriate handling, storage, and preparation of the vaccine. And for vaccinees, emphasize the importance of following up for their second dose to maximize their protection. Product and cold chain will be monitored in real time. If you could click again for me. Pharmacoepidemiology studies are obviously important to describe. Several safety studies are planned to continue safety data collection. These will access healthcare information from millions of lives to monitor safety events, including adverse events of special interest. We now have good evidence that our vaccine works in the clinical study setting and plan to investigate its effectiveness in real-world use. If you could click again for me, please. And finally, collaborating with vaccine safety stakeholders. At a previous VRPAC that some of you may have heard, as well as CDC meetings, we've heard about the FDA and CDC's planned programs for pharmacovigilance, including VAERS, the CISA network, Be Safe, VSD, etc. And we've shown you some of our plans, which are intended to be complementary to CDC and FDA planned pharmacovigilance activities. Next slide, please. We also intend to conduct a number of studies recognizing that there are other populations that stand to benefit, and there are other things that we need to learn about the vaccine. These include boostability, studies in pediatrics in pregnancy, use in immunocompromised populations. We also plan to explore our refrigerator-stable next-generation formulation and concomitant use with influenza vaccine. We look forward to expanding the safety, immunogenicity, and efficacy profile demonstrated to date. That ends my formal remarks, and so I'm pleased to have presented to you the safety and efficacy information that supports not only emergency use authorization, but we hope for recommendations for use of this vaccine. Thank you very much.
Thank you, Dr. Gruber, for that excellent presentation. So this is now open for discussion. I'm going to ask that the voting members be allowed to ask questions first, and then I'll open it up to the liaison members. Let me just pull open my window here. Okay, so let's begin with Dr. Paling.
Thank you, Dr. Grover. Thanks for this great presentation. I wanted to ask a few questions. The first is about the children enrolled. On slide 34, it appears that none of the 16 or 17-year-olds had any evidence of COVID-19 disease. And there were roughly, my understanding is there's about 283 16 to 17-year-olds enrolled. Is that correct?
Yes, that's correct. That's the number, obviously, within the safety database. We have 283 enrolled, a smaller number than that that have actually reactogenicity data, which is still being collected. As of this data cut on November the 14th, we have more enrolled as of now. In fact, up to over 700, I think, but that's not part of this data set.
Okay, thank you. I understood the materials correctly, I believe that there were 23 persons who were enrolled and received vaccine and were pregnant. Do you have any additional information on those persons?
Yeah, as you can imagine, given that, actually, can I answer your, Dr. Pulling, can I answer your other question? Because I don't think I did yet. You asked one question about the nature of, do we have any cases in the 16-year-old? And I've got other folks who help make sure I'm telling you the right things, but I know online that we can call upon. But my recollection is that we had none in the seronegative or individuals without prior evidence of infection, either based on nucleic acid amplification testing or serostatus. But we did have one individual who had evidence of prior infection, as I recall, in the placebo group. But that's the only individual out of that group that we have evidence for COVID-19 disease. But yeah, I'm sorry, I did want to make sure I answered that particular piece.
Okay, thank you. And then I wanted to ask about, there were a few people that were enrolled and became pregnant. And do you have any information about their health, having received the vaccine and being pregnant?
Others may chime in here. I'm thinking particularly of Susan Mather, but my recollection is that we have 23 individuals. As you can imagine, given the short period of time and given that the individuals were asked to demonstrate, or not demonstrate so much, but agree to adhere to contraception during the course of the trial, because we wanted to, obviously, we yet to complete our DART study, which will be completed by the middle of this month. And our plan is to actually begin to look at evaluation of the vaccine prospectively in pregnant women in the first quarter. For this stage, as we were capturing safety information, we cautioned individuals and wanted them to maintain contraception, both males and females. Nonetheless, not unanticipated, because we've certainly seen this in other trials, we still have individuals that become pregnant. We had a total of, my recollection as part of this data cut, 23. And so far, none of those have gone to term, because, of course, given the length of time, we just started this in the phase 2-3 portion of the study in July, so there hasn't been enough time for them to go to term. We've not had any reported outcomes in terms of related adverse events associated with the vaccine for either the pregnancies or the outcomes themselves to date.
Okay. All right, thank you. And then the last question is,
within that narrow age band, but I would argue almost any 2-year age band might be too narrow, right? It certainly is true that we have fewer people yet enrolled, which compromises the ability to have sample size. But for any 1 or 2 year age period, it might be difficult to demonstrate efficacy. I don't think there's any a priori reason to suspect that the efficacy would be any worse in that age group. I think, I gained confidence from the review that was done yesterday by the FDA and the VRBPAC committee that concluded the risk-benefit profile was satisfactory to include that age group. And I think we'll have more information over time. But I think that age group 16 to 17 is just too small at this point. And as I said, probably any 2 year age span might be too small to be able to make meaningful conclusions.
What was the thought then behind including the 16 and 17-year-olds in your EUA request if the sample size, population size was so small at this point?
Yeah, I think it was in part to begin to move forward into what we consider a critical population to be able to provide evidence. Number one, we have obligations, right, from the FDA to move into pediatric populations. This is a population that in a regulatory sense, and others can speak better to this than I, perhaps the FDA, including 16 to 17-year-olds is more of an adult population than they are a pediatric population. So to broaden the potential application and indication to encompass as many individuals as we possibly could, being confident about the likely safety given the data that we already had in 18 to 55-year-olds, we included them to get that safety information with an expectation that they would have the same level of efficacy as the rest of the older individuals. I will say, and I think this was touched on perhaps otherwise, we are actively looking at a population of 12 to 15-year-olds, of which we have about 100, for whom we already have some safety information that's been submitted to the FDA that obviously they need to review, but to us looks good in comparison to the 1855. Our potential concern was that somehow as we move further down into that age group, the reactogenicity would really amplify. That doesn't seem to be the case. We're expanding that population to a total of 2,000 children between 12 and 15 years of age, not only to serve, to potentially seek a license in that group by both the safety and immunobridging to the older group, but to also serve as a springboard for us to move into successfully younger pediatric populations, as I mentioned in that last slide. So bottom line, that's a long way to say the 16 to 17 we consider more like an adult population that served as another entree for us to move into the pediatric population so they don't have to wait too long before we can actually get information.
Thank you.
Dr. Alt.
I had a question about your study design, and it flashed by, and I'm not sure I got it straight. Did you exclude people who were seropositive at baseline from being vaccinated?
Yeah, so let me, yeah, that's there was a difference between what we chose to do in phase 1 of the trial versus what I showed you before. And if we can go to that slide, I'm trying to thumb here myself through here so I can find it. Maybe others can find it better than I can by scrolling back up in the slides, because I think it'd be helpful to have it up while we're talking about it. If we go, actually, if you go down, because I think I talked about it, didn't I, at the beginning of the efficacy portion. Well, yes, right there. Whoops, back up. Yeah, thank you. We can talk about these next 2 slides. So we recognize that from both an efficacy as well as a safety point of view, it was important to vaccinate both individuals who had had no prior evidence of infection. As I already mentioned, they're the most vulnerable. They're the ones that we'd be most concerned about protecting. But we recognize that many individuals don't know that they've been infected because it has been asymptomatic. And so we wanted to capture information both from a safety perspective and an efficacy perspective in that population. So what actually happened in this phase of the trial which is a little bit different than what we did in phase 1. So let me just focus on phase 2, 3 here, is when an individual came in at the time of that left syringe that you see for their first vaccine dose, they had blood drawn to determine whether they had antibody to the N protein, because the N protein is obviously distinctly different from the S spike protein that's the mRNA construct, or translated from the mRNA to the spike protein. And in addition to obtaining that serology, which would help us determine, that individual might have been infected months before, going all the way back to March, perhaps. We also wanted to know, well, were they infected at the time of immunization? And strikingly, and this was even before being in the current pandemic state over the summer, we had a small proportion of individuals who actually were, had virus identified by nucleic acid amplification testing right at the time that they were vaccinated. But again, the nature of that was not to exclude them, but for us to know, so that we could identify, okay, we've had so many individuals that have actually been infected previously and those that haven't, and what happens to them when we then follow them up. The same thing happens at the second dose. In effect, we also samplify by nucleic acid amplification testing at the second dose to see if they manage to now be, have virus identified at that time. So all of that information, the PCR information, as well as the serologic information, then identifies evidence of prior or concurrent infection at the time that they're being immunized. And those are treated, as a separate group from those that we claim as being without infection, which is based on the serology being negative and both of those tests by nucleic acid amplification testing being negative. But we did not exclude individuals in this part of the trial that had prior evidence of infection because, again, we thought it was important to know what happens in those individuals.
Then is the safety data for the people that were PCR positive or antibody positive, is that in the FDA briefing document, or could you give it?
Well, it's in the CSR. I don't know that we've actually spelled that out, but I summarized this very briefly yesterday. It's interesting that when you look at those individuals who basically had evidence of prior infection, and you looked at either their reactogenicity profile or their adverse event profile, we see no differences in terms of the nature of common systemic events or local events compared to what we saw in the individuals that had no evidence of prior infection. In fact, and again, I wouldn't claim statistical significance for this, some of the point estimates were actually lower. In other words, the point estimates of what we actually observed for some of the systemic findings were actually lower. So I think we have some confidence that giving the vaccine to individuals who had prior evidence of infection, either by PCR or being seropositive, did not differ from individuals who were naive, and this was their first exposure to the S antigen.
Thank you. That was my question.
Dr. Lee, please.
Thank you. I just have a series of clinical consideration questions for you to ask or clarify. One is, could you please clarify what the range of timing for dose 2 was? I realize the intent is 21 days, but what was the range in the data or in the trial?
Yeah, I don't think I have this on the slide. I think you may know from the protocol that we allowed a range of 21 to 42 days as being per protocol. As you can imagine, in a well-controlled trial, most of the individuals were close to 21 days. But we did have some individuals that went out to 42 days, and we had some individuals that went out even beyond 56 days, although that was a small fraction. I don't know if one of my colleagues has that readily accessible. I know I've seen the numbers before. Maybe I'll call upon John Perez. I realize I'm putting him on the spot, but I will, while he's potentially looking that up, I will say that most of the individuals were centered around the 21-day date, but we did have individuals going farther out. And I think most of us would be pretty sanguine about the prospect that a longer interval is unlikely to be associated with a diminished response. In fact, it's more likely to be associated with a better response to the second dose. We don't yet have that type of information because we've not done enough of the immunologic evaluation on the full cohort of individuals in the trial. I'm hopeful that that might give us a bit of a clue once we do that. But you know, that's the most I can probably say now. I don't know, with the chair's permission, can I call upon John Perez from Pfizer?
Yes, yes,
Okay.
you can.
Well, I was just going to actually maybe ask a couple more questions, and then that would give them a chance to look it up if that's possible, just getting the trial data, because you might call on colleagues and friends for this. The second question I have is on slide 21. The day of vaccination, is it day 0 or day 1?
Yeah, that's a good question. I thought I said that when I was talking, and maybe I skipped over it, when I was talking about the duration of symptoms. If we can go back to that slide, if you go back a few slides here, just so we have that.
Sorry, I thought it was 21. It's not. Maybe one back?
Yeah, keep going. Keep going. Yeah, it's back to 21. I think you're all the way at, yeah, I guess part of it's because, here we go. Yeah, here it is. So yes, yes, the vaccination was given on day 1. So it's really in that first 24 to 36 hours, and particularly that, you know, day after vaccination, often really sort of the morning, the day after, you know, and others that are on in the Pfizer group may want to comment on this, that we typically saw people talking about, you know, the chills or the fever that they saw.
To that point, can we take a look at this by proportion of individuals with any systemic symptoms that are mild, moderate, severe, and grade 4? Because when you're planning a vaccination program, it's important to understand what proportion might actually need to miss work, regardless of symptoms. You know, we're focused on fever for sure, but you know, understanding on day 2 post-vaccination, for example, what proportion of the workforce might be out.
I can't recall if we actually have any slides in this set. I'm not sure that we do. I know that there have been some specific questions, perhaps along those lines requested by the working group. I don't know. Maybe I could call upon John Perez or Vinnie Snow with the chair's permission to speak to those 2 issues.
Okay, one last question to fit in, and then I'll ask the chair. Timing of anaphylaxis, do you have a sense of whether it was within 15 minutes, within 5 minutes, within 30 minutes?
That I'll call upon Susan, because I think she's been the closest to analyzing the data. So I think we've got some questions for John Perez, perhaps Vinnie Snow, and Susan to answer the chair's permission.
Dr. Gruber, please, the purpose of these questions are to gather evidence and insight into what you're presenting. So please, no need to ask permission. Okay. Just go ahead and call who you feel is appropriate.
Okay, great. Thank you. So maybe I'll start with you, John. I don't know if you've got that other information handy. And you may be on mute.
Hello, could you hear me?
Yeah, now we can.
I was double muted. All right, so what I can tell you for the dosing question is that we did allow people to have doses anywhere from 19 to 42 days in the efficacy analysis. Most, of course, hovered around the 19 to 21, 23 days, but that was allowed in the analysis.
We do have the breakdown. I mean, we can obviously provide that back to the committee because we have analyzed that. It's a question that I think came up in another forum, where we can get that information to you.
Thank you.
And then I think there was a question about any reactions. I don't know. I know there's been a lot of back and forth providing information both to the FDA as well as the CDC. I know that there was a question for each of the individual outcomes in terms of any fever, any chills, adding up between dose 1 and dose 2. I think you can sort of gather from the nature of the relative infrequency that existed with dose 1, there wasn't much added beyond what was being seen in dose 2. But, Vinnie, perhaps if you want to take that or others that have helped put that information together. Again, those colleagues may be on mute as well.
Hi, this is Vinnie. Can you hear me?
Yes.
Oh, terrific. So
One moment, I'm just bringing the data up. We have for any local reaction or serious adverse event in the active vaccine group, we have 362 cases, and in placebo, 84. For the vaccine group, that would be 8.8%, and for placebo, 2.05% of participants.
I'm sorry, Vinny, that was for any local or any systemic or what was it?
For both. For grade 3, any local or systemic.
Yeah.
Oh, okay. Yeah, do you have a sense of any systemic reactions, moderate, severe, or grade 4? Or if you can get that to us later, that'd be great. I don't want to hold up the meeting, but that information I think would be incredibly helpful for employer-based vaccination programs.
Yeah, I think what you're asking is to actually break that down, not include the locals within it. Is that what I'm hearing?
That's correct.
Yeah.
And we're really concerned more about, what proportion of the population may need to miss work, because as you can imagine, for healthcare worker vaccination, and given where we are with the pandemic, we need to retain the capacity of our healthcare delivery system. And so we're trying to time this, but it's like a little bit of a guessing game without more clear information at the individual level as opposed to the symptom level. And then the final question was around anaphylaxis.
Yeah, so Susan, Mather, you want to come back and describe that one individual that had, and I think you're focused on the person that, again, we didn't have any anaphylactic reactions, but the one individual we cited that was in the group of individuals that had prior allergies. Is that what you're asking, the timing of that particular individual?
Or if there's any knowledge of the cases outside the U.S. that may have occurred, but just in terms of timing. I apologize if it's publicly available. I just haven't seen it.
Yeah.
Again, for planning purposes.
Yeah.
Yeah,
Go
can
ahead.
you hear me? So the two cases that were reported from the UK, both of the women had their reaction started within minutes. So about 2 minutes, and the other one just said within minutes.
Thank you.
Sure.
Does that conclude your questioning, Dr. Lee?
Yes, thank you very much.
Thank you. Dr. Atmar.
Thank you, Dr. Romero, and thank you, Dr. Gruber, for a great presentation. I have a few questions related, just clarifying questions. One on slide 2, it indicated the vaccine could be stored at 2 to 8 degrees for 5 days. Is that correct?
Yes, that's correct. I don't know if we have individuals, and many you'd know in our collection of experts, but yes, so it can be kept at refrigerator temperature for 5 days. Okay, thank you. And in the briefing document, it indicated that residents in long-term care facilities were a potential target for enrollment. Were there any from long-term care facilities that were enrolled? Yeah, we actually asked this question before or in another forum, and to my knowledge, we have not been successful, or if we've been successful, it's minimally successful in terms of recruiting from that environment. I think, as you can imagine, one of the challenges is just the nature of trying to contain those environments because of the incredible risk and the incredible potential for spread. So logistically, we found it challenging, in addition to the nature of getting informed consent, et cetera. My hope is that the evidence that we're presenting based on risk and age condition combined, where we've actually looked at it by both age and risk and shown efficacy, will translate into effectiveness in those populations. And I think, there are some plans to look at special populations, potentially long-term care facilities, post-licensure. But the hope would be that serves as a good surrogate. Sure. I think we just had some discussions with the assumption that you would not have had any, and it looked like there was a possibility there might be a few, so that's why I was asking. In terms of efficacy or looking at cases in seropositive individuals, my reading of the briefing document is that there were 8 cases, 7 in the placebo recipients, and persons who had prior evidence of infection. Is that correct? I mean, too early to really get a
good read on efficacy, but
it can be a challenge to take that 1-7 split and say, oh, gee, that must mean that all of those individuals were seropositive or had evidence of prior infection based on PCR. I can actually have John, to tell you the individual groups while he's thinking about that and pulling up that information. But suffice to say, you either have infection. You either have had prior infection or you haven't. And so for the not having had prior infection, there's really specific criteria, right? You can't have anything that suggests that you were positive, either by PCR or serology. However, for the second category, where you include with and without, that includes individuals that you can document had prior infection, right? But it also can include individuals that you have incomplete information as to know whether they were positive, if you see what I'm saying. So,
okay. And did it include people who were positive on day one?
Like 5, and my recollection is, and John, you can correct me if I'm wrong, 5 of those individuals in the placebo group, basically, we either were missing a PCR or we were missing serology. So all we could say is they were infected. We can't say whether they did or did not have infection. I think the breakdown otherwise, in terms of either PCR positivity, if I'm remembering this right, was 1-1 as far as the seropositives and 0-1 for individuals identified by PCR. And then I think the other 5 were basically individuals that we did not have information either way.
Okay, thank you. How about on dose 2? How many persons were PCR positive then, and what was the split? Do you have that information?
I don't know that we have that at our disposal today. We obviously can look at that information. Let me maybe ask John, now that you had a chance to think about this and pull up stuff, to see if you can inform that question.
There was one person in the vaccine group and one person in the placebo group who were positive at baseline and had COVID after dose 2.
Okay, thank you. And this is maybe whether it's a question for you and or maybe for Dr. Fink. You've indicated that you'll look at further data cuts in conjunction with discussions with the FDA, and I know it came up as a question yesterday, but is there an estimate either from you or from Dr. Fink in terms of when that next data cut may be to inform us further about efficacy a month later and maybe with more information in the subgroups?
I'll give you my perspective. We also have regulatory colleagues on, and obviously if Dr. Fink wants to respond to this, you should feel free to do so. We have not yet engaged in a discussion about the next step in terms of what the best timing is from our perspective. Obviously, over time, we have the potential to gain more information about total cases, as we already talked about, enrich the numbers based on demographic groups, which would provide more precision around that. Obviously, also have some potential information that can inform durability of protection, as well as severe disease. So, these are things we obviously want to do, and I think, in relationship to the BLA filing, we will do. The question is, whether there's a time in between now and then that it makes sense. I think we have to have those discussions.
Hi, this is Doran Fink. So I'll second what Dr. Gruber just laid out. We still have to have those discussions.
Okay, thank you. And my final question is, you looked at vaccine efficacy in a number of different subgroups, and really from the data you showed us, there was not any particular group or characteristic that was identified that was associated with vaccine failure. Is there, looking at all of the data, was there any characteristic that was that y'all identified that might have been associated with vaccine failure? It's a small number and maybe it's too early, but
no, it's a good point. likewise, when the vaccine has this degree of success, it's harder to identify common themes, right? But so far, we've not identified a theme. We had a number of hypotheses, one of which was, could it be that it's not an actual issue in terms of people failing to make an immune response, but it's a failure, for them to have actually, gotten the vaccine where it needs to be. And I'm thinking particularly people that are morbidly obese, right? So the notion is, well, maybe the needle doesn't get into the muscle and you don't get an appropriate antigen presentation. But I don't think we've had any evidence that convinces us that that's the prevailing reason why we have 8 individuals who were previously negative that have failed. I think we just need more, sadly, more cases over time to be able to begin to dissect that. And of course, one of the key ingredients is going to be looking at the immune response in those individuals. We have sera on everybody in the trial, and when we ultimately perform the serologic testing, that may give us a clue that they, in fact, yes, they really, for whatever reason, didn't make a good immune response, and then maybe that serves as fertile ground for trying to figure out why.
Another reason to consider cut before BLA, but anyway, that's my 2 cents. Thank you very much. That concludes my questions.
Thank you. So I want to ask the voting members to please, if possible, and I don't want to stifle questions or discussion, but we have a number of individuals to still get through, and we have a time period to do it in. So please limit your questions to 1, maybe 2 at the most. And so, Dr. Szilagyi, please go forward.
Thank you, Dr. Gruber, for a very clear presentation and impressive results. One question about anaphylaxis that has not been asked, or a couple of questions about this. Can I assume that there were no exclusion criteria for prior anaphylaxis in the study?
Yeah, so let me explain. We did have one exclusion criteria, which basically was that if an individual had an anaphylactic or severe allergic reaction associated with a prior vaccine of any kind, or they actually were known to have had a reaction to any of the excipients or constituents within the current vaccine, they should not be included in the trial. But a prior history of allergy, and you can already see that we had over 5,000 per group that had prior history of allergy, so that by itself was not an exclusion. I don't know that we actually had anybody in the trial that had a prior history of anaphylaxis, but we did not exclude individuals except for that very narrow definition, which in many ways, of course, corresponds to a definition that typically appears in labels, that if you've had a reaction to the vaccine or other excipients in the vaccine, if you've had an anaphylactic reaction, that the vaccine should either great caution should be given in giving the vaccine, or it should be contraindicated.
Okay, thank you. So it was very narrow. That's what I was getting at. Okay, and then if I could just ask one question, this is clinical consideration, and regarding the common effects, fatigue, headache, fever. Did you do, because the age range 16 to 55 is so large, did you do kind of a sub-analysis about the how common these events were among a much younger age group, such as, for example, 16 to 30? There's a significant difference between 16 and 55 and an over 55, but is it possible that a majority of the individuals who received the vaccine who were young had these symptoms? And this is simply just because for clinical considerations and advice and what to do in the workplace, et cetera.
Yeah, it's a good question, and we actually have done some analysis in the 18 to 25. I'm going to maybe call it again on John Perez while he's thinking about this or pulling something up. There was a general tendency, just as there was in the over 55 versus the younger group, to have some increase in reactogenicity as you move down, let's say, to the 18 to 25-year-olds. But that still was felt to be within a tolerable and acceptable range in comparison to other vaccines. That actually has become, I think, the key metric that we've used for looking at the 12 to 15-year-olds to give us comfort to continue to dose in that group. We dosed the first 100, and obviously during that period of time did that in a staged way to make sure that we were not creating undue reactions, and then did a comparison. And after that comparison, have elected to expand from that 100 to the full 2,000. So, again, it was our sense, and again, the DMC sense, which I should say, they obviously have looked at this independently, to proceed as planned. So I think if we don't have that information readily available, we can make it available in terms of what we saw in the 18 to 25-year-olds. I don't know, John Perez, if you want to say anything more about that.
Yeah, so the 18 to 25-year-olds look like what we had called our 18 to 55-year-olds. In other words, reactogenicity was a little bit worse after the second dose, but still within a reasonable range. We also compared 12 to 15-year-olds, those 100 subjects with reactogenicity data in 12 to 15-year-olds, and actually did not see an increase in the reactogenicity rates that we saw in the 18 to 25 or the 18 to 55-year-olds. So and that was encouraging us to go ahead and continue to enroll that age group.
Okay, thank you very much.
Thank you. Ms. Bata.
Thank you. I'm very glad that Dr. Lee asked most of my questions. And thank you again, Dr. Gruber, for this incredible presentation and the information you're sharing. Any idea when we might hear about the fertility and developmental study results? I know we're close to mid-December, but
each passing day, right? Yeah, I think again, we're expecting that's the first set of results, and then we'll have more comprehensive results. I think that the key element is that we're anticipating sometime by the end of the first quarter, if not before, but I expect by the end of the first quarter is when we would actually be in a position to have enough information, obviously have that undergo the appropriate review by the FDA or protocol, et cetera, and then be able to move forward. So that's our target. We're moving forward as quickly as we can.
Thank you.
Dr. Sanchez.
Dr. Sanchez may be having audio problems again.
I was about to say the same. He took the words exactly out of my mouth. We'll come back to him. Dr. Fry.
Thank you, Dr. Romero, and thank you, Dr. Gruber. I have three questions, so I'm going to make them one very briefly. I have questions about disease processes, and so very briefly, did you see any new cases of or flares in any autoimmune disease? Did you see any cryptogenic or idiopathic pneumonia that was worrisome? And also, did you have any reason to think there were any cases that might be Th2 related to an increase in Th2 response? Thank you.
So for each of those, obviously we're looking for the potential for enhanced disease. I think other markers that might suggest that or changes in it's not only important, obviously, in terms of what we observed with the DMC that's obviously been looking at this, and it's obviously continued to look at data past the November 14th data cut, right? And so even with that more comprehensive data, to my knowledge, there's been no indication of any sort of autoimmune disease, adverse splits that would cause concerns. I think no evidence of any sort of idiopathic or funny sorts of manifestations. I mean, thinking back to things like atypical measles, some unusual, presentation of disease. And I don't think, we've seen anything suggest Th2 bias, although, obviously we've not looked at that beyond the German trial in terms of the original responses to the vaccine. So, and, I think we all take great comfort in the fact that the nature of what we're seeing in terms of protection beginning after the first dose against severe disease, it gives me comfort in a circumstance where we know there's been huge exposure out there, particularly and growing, sadly, in the United States.
Thank you.
Thank you. Ms. McNally.
Thank you. Dr. Gruber, I am the consumer representative on ACIP, and I just wondered if you could talk briefly about the safety of this vaccine for women who may be pregnant or may want to become pregnant, and I understand that data will be coming. Thank you.
Yeah, I think this may be a question to come back to the FDA. All we can say at this point is that we purposefully did not include pregnant women in the study. There's no a priori reason to suspect that this vaccine would be associated with problems in pregnancy. We'll have a fuller understanding, obviously, once we have the development and reproductive toxicity or the DART studies completed. But I would say at this point, we have no information either way. But a priori, I would say there's no particular reason to expect that this vaccine would be associated with increased risk.
Thank you.
Thank you. Let me go back to Dr. Sanchez and see if his audio problem has resolved. It does not appear to be. Dr. Wharton, please.
Thank you, Dr. Romero. Dr. Gruber, I had a question about the appendicitis cases that were described in your briefing document. There was an imbalance between the vaccinated group and the placebo group, although the overall numbers weren't large. I was interested in the distribution of times post-vaccination for the appendicitis cases among the vaccinated group, and to know if there was any evidence of temporal clustering.
Yes, let me address what I can of that. I don't off the top of my head remember details about the temporal clustering. I should say that the reason this sort of bubbled to the top is obviously when we first started seeing the appendicitis cases, we took that seriously as a potential life-threatening event, and so looked at them with a great deal of scrutiny. And match them up with what one might expect in a population of this size, matched for the types of demographics and the nature of the population, and the frequency with which this condition was occurring seemed to be, not outside the bounds of what we might expect in a population at large. In addition, we presented actually all of that information in a blinded fashion to the DMC, and of course they had the ability to look at this in an unblinded fashion, and they have not indicated to us that they see this as an important signal. But I don't know, Susan or John, maybe start with Susan, who can speak to the nature of the comparisons that we did, and if we know anything else, maybe Susan or John, about the nature of timing.
Yeah, now I can talk about the 12 grouped together, not in an unblinded down to individual patient level, but I can tell you that the latency in the cases that occurred after dose 1 ranged from the same day of dose 1 up to 16 days. And then the ones that occurred after dose 2 ranged from 11 days to 28 days. So overall, we have a single case that actually occurred on the same day as dose 1, and then it went up to 28 days after dosing. Is that getting at the question?
Well, I mean, that's part of it, but I'm actually interested in the dates that the cases occurred in the vaccinees related to vaccination. And the reason I'm asking this is because the vaccine did result in lymphadenopathy among many recipients. Asking what the timing was between receipt of vaccination and appendicitis in the vaccinated group.
I think one of the challenges that we face, and this is something we try to manage carefully, is with an ongoing trial, not unblinding individuals at a subject level. I think we can speak in groups, and perhaps we can provide some of that information. I will say that obviously the DMC was privileged to know that information. They have a fair degree of sophistication around the potential for adverse events associated with an immune response, and they saw fit to have us continue the trial. And the FDA can obviously speak to their evaluation of this, which they, I think, did in their briefing document, and felt that this was not something that suggested a relationship to vaccine. But I don't want to speak for the FDA. They should obviously speak for themselves.
Thank you very much. Dr. Sanchez, who I think may get a medal for persistence in this meeting. Are you there, and can you speak? I think he still is having audio problems. Maybe you can text me your message, and I would be happy to relay it to Dr. Gruber. I see Dr. Paling's hand is up, but oh, there.
Does the vaccine contribute to any positive antigen detection in when antigen tests are used for detection of SARS-CoV-2 infection?
I'm unaware of any ability to detect antigen on the basis of vaccination. Obviously, it's minute amounts that are being produced locally. I don't know. I think maybe Dr. Dormitzer, Vinny, remind me if Dr. Dormitzer is on. He might be able to speak to the nature of the likelihood of that.
Yes, I am on. Phil Dormitzer, Chief Scientific Officer for viral vaccines. We haven't specifically tested whether if you immunize, you would then see antigen. But I agree with Bill that it's extremely unlikely that the quantity of antigen would be enough, or that there's a clear path for it to get to from expression, say, in a muscle or local lymph node to actually be shed in, for example, a nasal swab. So I think it's a very low probability.
Thank you. And then my other question is, as you're aware, there's a lot of vaccine hesitancy around the country, not just with COVID-19 vaccines, but also for a variety of reasons, including religious ones. And one of my particular question is, was there any fetal tissue or cells that were obtained from abortions that were utilized in the making?
These are quite standard cell lines used in medical research that would have had that origin. But in the actual production of the vaccine, there are none used.
Thank you.
Thank you very much. So thank you all for your questions, and thanks for the patience of the liaisons. I'm going to open it up now to questions from the liaisons themselves. Dr. Stinchfield, please. 1 to 2 questions, please.
Yes, Patsy Stinchfield from NAPNAP. I just have one question related to the subject's infection prevention behaviors. Do you know, did you ask about mask wearing, hand hygiene, social distancing, and if so, were there any differences in your 2 groups?
Now, to my recollection, we did not ask specifically about those sorts of precautions. It's my sense that the investigative sites emphasized that we could not guarantee, obviously, that this vaccine was going to prove effective, and so it was important for people to continue social distancing, masking, et cetera. But to my knowledge, there was not something specific in terms of tracking that behavior.
Thank you. Dr. Middleman.
Hi, thank you. That was a wonderful presentation and a fabulous conversation.
As a practitioner, I'm trying to sort of back up a little bit. The CDC has mentioned that many people are behind on vaccines. And when people come in for their COVID vaccines, it's going to be a wonderful opportunity, potentially, to help catch people up. Is there any data that would help guide us about the safety of co-administration of other vaccines? And did the FDA comment on whether it would be best to just do COVID vaccine when seeing a patient, or whether co-administration should be would be ill-advised or recommended?
So this is Bill. I think I heard that you're asking the FDA. I mean, I'll just say from our perspective, we don't have data, again, one way or another.
Lumping and improvement might be less.
Right. I mean, I think, again, in the original, phase 1 study, we had a breakdown of 65 and above. But yes, we can look at that information. I'm expecting that we'll see that and again, of course, we start getting diminishing numbers of individuals as we get higher up in age, but we do have the age spectrum out now even above 85. And, we ostensibly can gather that information. But again, I say my expectation is that the 65 to 75 group is going to have less reactions than the 55 to 65, and likewise, 75 to 85 will be even less.
Great. Love to see the data.
Thank you. I want to remind everyone to please lower your hand after you've had a chance to ask your question. Dr. Freihofer, please.
Sandra Freihofer, American Medical Association. So this is an mRNA vaccine that's surrounded with a lipid nanoparticle. What evidence is there that the mRNA is degraded, and what happens to it the messenger RNA and the lipid nanoparticle after it's injected and done its job, and how long does it hang around? How is it broken down? Is there any concern that this could cross the placenta?
We'll ask Dr. Dormitzer. We've obviously spent a lot of time thinking about these sorts of questions, so I'll defer to Dr. Dormitzer.
Can you move a little closer to your microphone? You faded away there.
Gosh, I'm on top of it, but yes, okay. Anyway, I'm going to ask Dr. Dormitzer to respond to that question.
Thank you.
So I suppose there are three components to that question. What happens to the particle? What happens to the RNA? And what happens to the lipid? And I'll keep my answer brief because one could go on for a long time about this. The belief is that the actual lipid nanoparticle probably doesn't last all that long, that once it starts to enter a cell, that at that point, the lipid would fuse with the cell membrane, releasing the RNA. Now, the RNA would be metabolized by the usual pathway that RNA is metabolized by. The lipids have different things. Cholesterol, obviously, would be we have cholesterol anyway. And the other lipids there's some information on how they're metabolized. And so to some degree, they are either broken down. For example, the PEG comes off of the PEG-related lipid. And others actually wind up secreted as well through the liver. That's a general answer. In terms of crossing the placenta, here I think we have to rely on general principles because, of course, we never actually measured what crosses the placenta, but the placenta poses quite the barrier. And so for an intact lipid nanoparticle to cross the placenta, it's hard to imagine a pathway by which that could happen. In general, there's quite selective transport across the placenta. So we do not believe, certainly, that any intact lipid nanoparticle would cross the placenta into the fetus. To answer the question again, there's a tremendous amount of detail one could go into on this topic.
I would just add to that, again, we will have development toxicity.
We can't hear you. Please get closer to the mic.
Goodness, I don't know why that happened. Can you hear me now?
Yes.
Yeah, okay. Yeah, my apologies. I don't know what's happened to the audio. Yes, the other thing I was just emphasizing, we will have development and reproductive toxicity studies in animals that will better inform
Dr. Gruber and team, are you ready?
All virtually located elsewhere, but I'm ready. Can you hear me, by the way? I put on a headset in hopes that that helps with the audio. Can you hear me
You're
better?
still a little, we can hear you okay, but you're still a little far away. You seemed closer and louder during the initial part of your presentations.
Okay, well, I'll try to
I don't believe people with this history were excluded from the trial, but could you comment on that? And then as for allergy, how long would we be expected to monitor people post-vaccination? And would that differ between those who have a history of some sort of allergic reaction versus those that don't? And then lastly, and I realize this may be more of a question for Dr. Fink, would we expect to get the EUA fact sheet, which I
be the first and the last question, or a question for Dr. Fink. I think, as I've already stated, that we do not have data in immunocompromised populations or individuals in pregnancy. And I know that negotiations are ongoing as far as the label is concerned, and I'm not the best person to speak to that. As far as monitoring is concerned, that also is to some extent a labeling or a recommendation issue. I don't see, from my perspective, a reason that one would, respond any differently to people than we typically do in terms of having to monitor individuals in a setting. As we said, we have within many, if not most, labels for vaccines precautions around being prepared to deal with an allergic reaction if it occurs, and monitoring individuals for a period of time. But I defer to others that have to make those recommendations and from a regulatory perspective, have to have that information in the label.
Hi, this is Doran Fink, and before I answer the question, I want to apologize. As you can imagine, it's very busy at FDA today, and I've had to jump off to attend to several